we will go ahead and get started.
Thank you, Janet. And I'm Deborah Frazier, as Janet said, representing the National Healthy Start Association and AIM CCI. And thank you all for joining us today. And so in this webinar, we'll provide an overview of AIM CCI's community-based approach and talk a little bit about AIM CCI's maternal safety bundles. And that conversation will be led by, as Janet talked about, our bundle queen, Dr. Ashley Calderon. And then we'll talk about the AIM CCI and how it supports the postpartum and fourth trimester safety, and then talk about Nikki will talk about how AIM CCI partners, as one of our pilot sites, understands the work and implements the work of CCI in our pilot site in Newark, New Jersey. And so in this next slide, we can see AIM CCI is actually I think the question was, what is AIM CCI? So in the next slide, we'll talk about a little bit about what AIM CCI is. So AIM CCI is actually the Alliance for Innovation in Maternal Health Community Care Initiative. And so for some of you, you may be familiar with AIM within the hospital setting, but the Community Care Initiative is actually the development and implementation of non-hospital focused maternal safety bundles. And so what we did was build on the foundational work that was done in hospitals, but take that work outside of hospitals and bring together non-hospital community providers to work on addressing maternal health and safety. And there was one agreement that was awarded to the National Healthy Start Association for this 5-year pilot period beginning in 2019, from 2019 to 2014. So in this next slide, we'll talk a little bit about what this pilot site, the pilot sites look like, and why, in fact, HRSA decided to focus on non-hospital bundles. So as most of you who do this work in maternal health know, for that period that HRSA was looking at data, and as most of you know, again, so many of the deaths to women, and then looking at both morbidity and mortality, some of the deaths do occur during pregnancy, and AIM was very successful at addressing morbidity and mortality within labor and delivery within the hospital setting. But then when we began to look at morbidity and mortality outside of a hospital, so much of it occurs in the postpartum period and in non-hospital settings. So it made perfect sense for HRSA to look at how they could address this in non-hospital settings. But again, this is a pilot because it had not been done before. So the idea behind CCI, the Community Care Initiative, was to bring together providers, a variety of providers at the community level, many of whom had been working in their own silos, to come together and think about how they could work together to address maternal morbidity and mortality, and to share their data and to make a difference in improving morbidity and mortality for maternal health. If we could move to the next slide, please. So what I just described is this slide here. So you can see the different the approach of AIM CCI and the different kinds of organizations that are represented here. So in these sort of concentric circles, you see a place for the implementation group. And this group meets monthly because these are the groups that meet what we call our local maternal safety work group. These are the organizations that actually will be implementing the bundle elements that Ashley will talk about later on in this presentation. And they will be implementing the bundle elements, collecting and sharing the aggregate data related to performance measures, and then reporting that back as a community to look at their progress. And then the circle around that is the advisory committee. And that local maternal safety work group meets the advisory committee biannually, and they have a different relationship. And then the larger circle outside is the awareness circle. And that's a circle that's also important because that's a circle of faith-based organizations, policymakers, and others who we want to have an eye on and a vision on and reporting out on the progress of maternal morbidity and mortality. That's really important. So moving to the next slide. This demonstrates where our pilot sites are. So in purple, we have our 6 original pilot sites in Fresno, California, Tulsa, Oklahoma, New Orleans, Atlanta, Georgia, trying to go from memory here, Grand Rapids, Michigan, and then Newark, New Jersey. And then we have implementation sites in Florida, South Carolina, Virginia, Pennsylvania, and New Hampshire. Next slide, please, Janet. Okay, so when we began this, we began it looking at and looking with a health equity framework. And actually, I think a framework probably doesn't do justice to how we view equity within AIM CCI. So, and I want to give kudos to many of you know Dr. Vijaya Hogan, and so she was part of our writing of this approach and our voice of equity when we started this program. And we started it looking at morbidity and mortality for maternal health, and you couldn't escape the disparity in outcomes. And we knew from the onset that we had to do this with not, as she said, not just an equity approach, not just with an equity lens being something you could put on and take off. But she introduced us to the word inculcate, meaning that equity had to be woven throughout this in a way that it couldn't be untangled. And so inculcate is the word that we use now when we talk about equity in our work. And so equity is inculcated in the work that we do in AIM CCI and throughout our organization. So we look at equity and think about why equity is important. And again, I described why we took this approach, and this slide pretty much demonstrates why equity is important. It's important in maternal health, but it's important in all the work I think that we do in public health, particularly when we begin to look at disparities. But this slide demonstrates why it's important in maternal health, looking at this data, and why it's important for us to think about why women should have access to equitable care, regardless of who they are, where they live, or what they look like. And so that's the approach that we take across the Healthy Start program. And we've implemented, can I see the next slide, please? We've implemented, we talk about equity, we've implemented the Racial Equity Learning Series. Again, working with trying to think through how to inculcate equity. We wanted it done in a way that it was standardized across our programs and standardize in AIM CCI in a way that every person who touched a woman, whether that person was the front desk person, as Dr. Brown said, or the provider. And all of us have heard stories from whether it's Charles Johnson or someone else about the way they were treated by a provider. But sometimes it can be the front desk person that means that a woman or a family doesn't come back to care or doesn't get the care they needed. So we wanted to make sure that everyone who had an interaction with a family, with a woman, went through the same standardized training, and that every provider who was part of the local maternal safety committee actually had a dashboard and the same standardized training, and that all of our local maternal safety committee, a work group participants could have access to knowing that all of their providers were trained and had the same training and could actually measure a beginning and an end of the training. So with that, we work with Dr. Terry Wright to develop RELS. And RELS is that 7-part module designed to enhance the knowledge on equity, capacity, awareness, and implementation. And it moves from, on that 7-module course, from a person to a department to an organization to sort of, as it says, anchor racial equity across systems. And we found it to be extremely helpful. And it also has, it's free, and it also has continuing ed credits to it. And you can see the QR code here for anyone who has an interest in implementing that in their organization. And we use it in our organization too. It's part of our HR policy for any incoming staff to the National Healthy Start organization. Next slide, please. So we are all about including community voice. So both as a National Healthy Starters organization and as a for AIM CCI, this work would not be complete if we had providers at the table and not community voice at the table. So we encourage the local maternal safety work groups to include community at their table, but we wanted to also have community voice informing us. And you'll hear from Ashley later that the community providers actually inform the bundle elements that we've developed and piloted before implementation. But we worked with National Birth Equity Collaborative to do focus groups with moms, and with Dr. Derek Griffith at Georgetown to do focus groups with dads. And these are all moms and dads who had given birth within 18 months prior to the focus group convenings in each of the pilot site cities that I described earlier. And so these are some of the statements from the moms and dads from the focus groups that from NBEC and from Georgetown. And I don't need to read those to you. So we also know that social determinants of health are key drivers for maternal health outcomes. And so with that in mind, the foundational data elements for the AIM CCI bundles, social determinants were embedded as key drivers for those bundles. And so Ashley will talk to you a bit about that as she talks about those bundles, because we know that 80% of our health outcomes are influenced by non-clinical factors. So we were really intentional about including bundle elements that address those key drivers, or address social determinants of health. And so one of the foundational elements of each of the bundles requires stratification of the data to include social determinants of health and other identifiers such as race, to include or to understand the driver outcomes beyond just clinical, besides just clinical indicators. So it would include things like food, food access, trauma, anxiety, depression. And again, I want to point out that these were community providers who do this work day in and out at the community level who are helping to inform that. So to inform the bundle elements. And we're really proud of the work that they've done on this work. So the next slide, please, Janet. So with that, I'm gonna let Ashley talk more intentionally about the maternal safety bundles, and talk about the beginning with the introduction to our community care bundles, and just mention that our first bundle was a doozy. It was it helped Ashley to earn her crown. We started with the postpartum bundle that was a bundle that was originally written at ACOG. It was a 2-bundle package. And we sort of had to work with it to with our community providers to make it something that the community could integrate into their practice. So that was our first bundle. And I will let Ashley talk about our subsequent bundles that we piloted and how those have been implemented. And Nikki will follow from there on the work that they're doing in Newark and the other sites as well. So I'll turn it over to you, Ashley.
Thank you, Deborah, and thank you for honoring me again with the title of Bundle Queen. I'm in great company with Deidre and Sue on that. So good afternoon, everyone. And you can go on to the next slide, please. So when we developed the AIM CCI postpartum bundle, again, looking at translating that from a clinical hospital-based bundle into what was realistic for community, we wanted to create a system of care for women and birthing persons from birth and looking throughout that entire first year of postpartum. So this bundle provides a structure to support those daily processes and organizational culture to ensure that no matter where a person presents in that postpartum care continuum, that they're receiving equitable care and that we're addressing not only their medical, but their behavioral health and their psychosocial needs as well. So we worked in partnership with members from our National Maternal Safety Committee, our subject matter experts, and very importantly, our pilot sites to refine the elements of those original 2 AIM bundles, and again, make those applicable for community-based providers. And I really can't stress enough the importance of having the community voice at the table and that real boots on the ground, just voice of the community to inform us on not only what was needed in these bundles, but what was feasible and realistic for implementation and considering capacity needs. As Deborah mentioned, we also added foundational elements that span all community care initiative bundles. And those foundational elements they're rooted in equity and call out the importance of stratifying that data. So Deborah also mentioned the Racial Equity Learning Series, and we feel that the need to center equity and define equity across the group in a similar way is really critical to set the tone for bundle implementation. So implementing RELs is not only a foundational element, but it's what we recommend as one of the first elements that is implemented across the local maternal safety work group so that we are centering what does that definition really look like? And we know that regionally that can vary dramatically in how we're looking at equity. So we want to set the tone on implementation going forward with that in a standardized way. Next slide, please. So you saw this slide before, but I just want to highlight again, why we are working with community and developing these non-hospital maternal safety bundles. These numbers are also the reason that we're focusing on the 4th trimester, right? We know it can make a huge impact when we're losing mothers, and that 65% of deaths occur after delivery and through that first year of postpartum. This is a staggering reality, and it's also a really great great opportunity for improvement. Next slide, please. So when we're looking at the 4th trimester, we recognize that ACOG's focus and recommendations have been pivotal in acknowledging the goals of pregnancy care, and that must go beyond achieving a healthy pregnancy and birth and must also ensure successful outcomes. That also means a healthy mom and healthy baby. So the Community Care for Postpartum Safety and Wellness Bundle acknowledges and aligns with those 2018 ACOG committee opinion paper. And while I don't want to speak on behalf of Dr. Brown, I do feel very confident in saying that this was and remains his passion to highlight the importance of optimizing postpartum care and the need to have that paradigm shift from a single 6-week visit and looking at more as a postpartum process. So the postpartum bundle calls out that need for clinical providers to ensure a touch point with all birthing persons within the first 3 weeks. This could be a home visit, it could be in a clinic in person, or it could be a phone call. But we just want to call out the need for some type of touch point, checking in and providing anticipatory guidance to that birthing person. In addition, the bundle encourages community providers, such as your doula groups, lactation consultants, community health workers, or even those faith-based organizations that was referenced earlier in the presentation, to reinforce the education of the postpartum period extending beyond 6 weeks and for that full first year after delivery, and then the importance of transitioning into well woman care. So this is a great example of how AIM CCI utilizes a clinical community integration approach. Everybody plays a different part, right? But we want to be speaking the same language and reinforcing that same education. And then in taking that even a step farther, the bundle uses very intentional equity language to remind providers of the importance of scheduling individualized, person-centered care, and taking into consideration not only the autonomy of a person, but in identifying and overcoming barriers for attending those visits. We want to utilize principles of trauma-informed care, cultural and racial humility, and cultural responsiveness. So after we created the postpartum bundle, we immediately knew that we wanted to address maternal mental health. We consistently heard from our pilot sites that those top mental health factors that they were witnessing were related to stress, anxiety, and depression. So with our esteemed partner and perinatal mental health consultant, Dr. Fleta Mass-Jackson, we led the development of our maternal mental health bundle, which was then tested across all of our AIM CCI pilot sites. So joining us today to tell us more about their AIM CCI experience in Newark, New Jersey, which included testing both the very large original postpartum bundle and the mental health bundle, is our partner from the Greater Newark Health Collaboration, Nikki St. Germain. And I'll turn it over to Nikki now.
Great. Thanks so much, Ashley. And so great to be here with you all today. Again, I'm Nikki St. Germain. I am representing Greater Newark Healthcare Coalition. So we bring you greetings from New Jersey. And we are a pilot site or an original site for the AIM CCI initiative representing and serving Newark, New Jersey. I thought it would be fitting to just do a little bit of framing just to understand who my organization is and just the individuals that we serve. So our organization is a nonprofit organization in Essex County, New Jersey. And some of you may have heard of Newark, New Jersey. And that definitely is a nucleus and focus of our work, along with other cities of East Orange and Irvington in New Jersey. And beyond us being a nonprofit organization, we also have been designated as a regional health hub. And that's been through our governor in the state of New Jersey to really just work collaboratively with other organizations, other folks that are at the system level, at the community level, to really just spark change and ensure that residents of our catchment area really are their best selves and receive the best sense of wellness through support, through accessing resources, and through the direct services from a clinical and a community perspective. With our organization, we do a lot of neutral convening between a lot of partners and many different areas. And as you can see on the slide here, our organization works in different areas of community health, child and adolescent health, and then maternal and infant health as well. So because that's a focus of our work, and because of the relationships that we foster as a regional health hub, it made sense for us to really go after the AIM CCI initiative. And we for sure jumped at it once we learned about it. Our organization was a previous Merck for Mothers grantee. Some of you may have heard of the Safer Childbirth Cities initiative for Newark, New Jersey, and other cities across the nation. But this is how we learned about AIM CCI, and it really helped to really develop and really add to the portfolio and some of the objectives that we have as we serve in maternal and infant health in that space. So some of the things that we focus on are priority-based, and that includes just supporting individuals who are Medicaid beneficiaries, and some of the expansion that really covers the postpartum period for individuals that receive Medicaid, and then supporting also just doula benefits that are allowed under Medicaid insurance within New Jersey as well. So that just gives a little bit of background and framing as to why it made sense for us to seize this opportunity. Next slide, please, Janet. So this is a very, very busy slide, and apologies if you definitely can't see some of the information here, but I wanted to highlight some of the work that we've done specifically around AIM CCI that we've presented just recently a couple of months ago at the AIM CCI Summit that was put together by the National Healthy Start in New Orleans, Louisiana. As I just mentioned, our organization learned about the opportunity through Merck for Mothers, and we really wanted to take some time to understand what the AIM CCI initiative was. It's a very innovative approach to quality improvement as we are testing out these non-hospital safety bundles as a community. So across multiple organizations, we are rallying stakeholders together to really do work collectively as we take a look at the best practices that come out of the bundles. So that requires a lot of coordination. And I was just sharing in a call before this that it really is a dance and a rhythm to be able to bring stakeholders together, to understand the objectives that we're working towards, to communicate that, and then get the buy-in from those organizations. So our work started by us really gathering some of the stakeholders that we know serve birthing people and families in Newark, New Jersey, and the surrounding areas, and really pulled them together to see if they were willing to test out these bundle elements and these strategies with us. As we did this work, of course, we had to pull together a diverse group of stakeholders that are really doing that groundwork that Ashley and Deborah both talked about. So we have folks at the table like WIC programs, Healthy Start programs. We have doula organizations, lactation organizations, folks that are county-based referral hubs, et cetera. And they're all coming together to understand how we can collectively service families and birthing people better in our region. So Ashley just talked a little bit about the importance of the fourth trimester and just doing that work within the postpartum bundle. And I'll share some work that has definitely come out of us just implementing the postpartum bundle collectively a little bit later after this slide. But I do want to say that we have, as a collective, as a maternal safety work group, have worked across 3 different bundles. So it is that postpartum bundle and that maternal mental health bundle that Ashley talked about, as well as one that's not currently published yet, but is looking at community care around the management of chronic conditions and pregnancy as well. We have seized the opportunity as an organization to understand what opportunities exist within the organizations that are part of our stakeholder group, and then how can we seize opportunities that our current organization already works within to be able to magnify things on a different scale. And a part of the implementation, there is a complementary data strategy where we do want to understand if some of our partners, as they're identified as data sharing partners, if they can share some aggregate data with us to understand if what we're implementing as a community is really making an impact. So we do have about 5 partners that share that data with us on a quarterly basis. And that helps us to understand what is happening and if the needle is moving. I did share earlier that our organization is a regional health hub, and we certainly help to make outcomes a little bit better for specifically Medicaid beneficiaries. And we have access to Medicaid claims data to take a look at what's going on with that specific population. And as we looked at some data for the calendar year of 2022, we were able to see that in our region, 79.4% of Medicaid beneficiaries in our region have attended a postpartum visit. And that data really helps to ground us. And as we look a little bit further from some of our data sharing partners through the AIM CCI initiative, we saw that just over 50% of individuals that service postpartum individuals in the region return for that postpartum visit within 12 weeks after birth. So AIM CCI has helped us to dig a little bit deeper to see where there are gaps that we can tackle. And that helps to inform what the work will look like. So if you could just move to the next slide, please, Janet, that'd be helpful. So this is something that came out of our 4th trimester work around the postpartum bundle, where we were able to adopt the CDC Hear Her campaign locally. And at first, we utilized the Hear Her content that was rolled out by the CDC, but we were able to tweak it to be able to make it make sense for the birthing people and families in our region. And we went after a platform where we have a domain that we facilitate called newarkmom.org. So you can feel free to scan the QR code on the screen, but we use some of the language from the Hear Her campaign to talk about the importance of the 4th trimester or the postpartum period, which is a very sensitive time, not just for the birthing person, but for their village, for their providers, and anyone that is having any interaction with folks in the postpartum period. So you can see that there's just some language, some graphics that have also helped to formulate a digital campaign that we have based on some of these images. And we really have a central location for all of the families and birthing people to come together to tap into county-based resources as they are navigating the postpartum period. So this is just an example of some of the work that the partners have contributed to collectively. And it really helps to just drill the message as different people are interacting with families in this way and during this sensitive time. So I'm going to just turn it back over to Ashley to take us a little bit further, to Deborah to take us a little bit further in our presentation today.
Thank you, Nikki and Ashley. And Janet, we would like to open it to any questions that anyone has who is on the call right now.
So feel free to come off mute and ask any questions. I see Tonya Luna, you asked a question and it's a little complicated, so maybe you'd come off mute and say it, explain your question.
Yes. Hi, everybody. Thank you. So we have a nurse navigator that we have hired to do exactly that and follow women in their 4th trimester. To try to get those resources and things. And what we found is we found multiple women that are still having preeclamptic type situations as well as other issues that are related to their pregnancy. And when we send them to the ER, something like they come in here for high blood pressure, whatever, we know it's related to their pregnancy. But when we send them to the ER, they just give them a script and send them home. And so we have kind of partnered with some of our hospital providers and told them we need to get together and train these ER doctors that if you see somebody that's been within a year, they need to be contacting OB and all that stuff. And so we're trying to find a way to combat that. But I was wondering if there was anyone else that's had that experience or had any different suggestions or have ran into that scenario while you're trying to help these women through that 4th trimester period.
Hi, Tanya. This is Kelly from Maine. I'm curious, one, why you send them to the ER and not to their OB provider? And
because we're a local health department and we only do low risk OB, and they are our OB, but we don't see them back here at the health department after so many weeks because it's a federally funded program. However, someone needs to care for them. And if that means bringing them back here, then those are things we're talking about. We just don't know as a community, everyone needs to be on the same page where how to handle those situations. And I was hoping that there would be some feedback from some of y'all how that might have come up.
We're addressing just what you're talking about doing in the EDs is training EDs it's actually in the AIM severe hypertension safety bundle. We're doing that. Yeah, it's important. Some people have instituted cards, developing cards to put on the carts and posters to put up in the ED to ask, have you been pregnant within the past year? And then, a checklist for what to do if somebody presents with severe hypertension.
That's a good idea. Thank you for those suggestions. I appreciate it.
Yeah. All right, Stephanie, you had a question?
Can I say one more thing, Janet, first in that regard? I'm sorry, Stephanie. But I thank you for bringing that forward. And in addition to addressing that in the AIM bundle, again, clinically in the, the hospital, we address that in the postpartum bundle from a community-based standpoint as well. And I think that the work Nikki and her team have done utilizing the CDC Hear Her campaign has encompassed a piece of that. Absolutely. Again, with the model that AIM CCI is recommending with bringing together those clinical and community providers to have that same conversation, I would encourage, if you're not already looking at the Hear Her campaign, definitely dig into that deep, and not only educating emergency room staff, but also EMS, again, thinking about who those touch points would be, and educating birthing persons on empowering them to know, to tell. Sometimes we still have to, we don't want to put that onus on the individual because the system needs to take responsibility, but educating them that speak up, right, and hear me, and their partners as well, that I am still in the postpartum period, even though it's been more than 90 days, and I cannot be treated as someone who's traditionally walking in with hypertension, but I need to be treated in a special way. So certainly would look at those. And then I think Nikki and a couple other of our pilot sites are looking into wristbands for folks to wear in the community. So again, identifying them as being postpartum. So if somebody comes in contact and sees there's high blood pressure, that they're starting to cue to think, oh yeah, I need to treat this situation differently than I would just, a normal, typical patient with high blood pressure.
Oh, thank you. All right.
Ashley, I have a follow-up question. I'm very interested in the wristbands that say, I gave birth within the past year, whatnot. And I'm just wondering if anyone's looked into the acceptability of wearing them. What kind of feedback people have received.
Yeah, that's something from our standpoint, I don't have that information. I know there are other organizations that have done so. Nikki just put in the chat, the Preeclampsia Foundation has done that. Off the top of my head, I don't know, but I'd be happy to look into that and share out. Another pilot initiative that our partners in Fresno are looking at, and Karen, I saw you just came on screen, so I don't know if you have anything to add to this. This is really your idea, was working with Anthem, which is one of their paying providers, who's a part of their local maternal safety work group, to sponsor blood pressure kiosks in a WIC office, so that when an individual is there for their WIC appointment, they can take their own blood pressure. So it's not a WIC staff person or a nurse taking it, they're taking it on their own, but it has a printout that they then can, look at with their provider and say whether this is falling in normal range or not. So hopefully we can identify a little bit earlier before we're in crisis.
Ashley, can you share your email address in the chat, please?
Absolutely.
Thank you.
You notice that Nikki also posted that the Preeclampsia Foundation's has information about wristbands. And so that may be also another place to find out how they're working and how acceptable they are.
So, hi, I will just take a minute. This is Karen, just to kind of comment on Tanya's first question about that and their experience in having to send patients actually to the ER. And we know that this is, you know, a touch point that we definitely need to concentrate on. I was at a recent meeting, actually it may have been the MHLIC meeting in Minneapolis recently, and there was a clinician who had done a presentation and with this exact same scenario, with her having to send a patient to the ER and it not having the best outcomes. And what she learned from that is, if at all possible, whether it's a physician sending from a private office or Tanya, your office at the health department, if there could be a primer for the ED to receive that patient. So, you know, actually calling to say, I am sending a, you know, patient who is postpartum. She, you know, her situation at this point is something we cannot manage. I need, you know, give them that heads up and a warm handoff to accept that patient, because she shared several, you know, situations where that had happened, where women were waiting, you know, for hours without recognizing the severity of their condition, you know, that having it been due to postpartum. So just if that is, you know, possible in the situation where you actually think that you have to send to the ED, if there's a way to establish even a protocol that you can do some kind of warm handoff, something to let them know this patient is coming and really does need to be seen, you know, immediately or urgently.
Great conversation. I don't want to forget Stephanie, you had a question.
Yes, my question was for Nikki, and your slide that I think also was reflective of a poster that you had done. You had that you looked at a culturally appropriate tools to screen for perinatal mood and anxiety disorders. And I wondered if you could share in the chat a link to the tools that you had used, maybe instead of like the Edinburgh postnatal depression screen. I would be interested in that. Thank you.
Yeah, no, thank you, Stephanie, for bringing that up. And I'm glad you were able to see that on the poster. So I'll just share that in Newark, New Jersey. So when we worked on the maternal mental health bundle, there was definitely a lot of energy around that, and particularly around screening. With screening, we found that the majority of our providers did use the Edinburgh screening. But when we started to take a deeper dive and get some of our partners to elevate the data, there were very low percentages of like positive screenings, right? So our partners started to open up about, you know, the challenges that they had with Edinburgh, especially with translations and not to be so culturally appropriate. And then we started just exploring through the AIM CCI initiative and connecting with other sites different alternatives to perinatal mental health screenings. So one of them came out of our colleagues in Atlanta, the Healthy Pregnancy Stress Scale that our partners have been exploring. And then additionally, as we work with some perinatal mental health specialists in our area, we've known that there have been some screening tools that have not been tested, but you know, are out there to be able to frame questions in a different way, to be discussion starters, and then risk assessments as well. So I'll try to grab some links to some of those. One of them is called the Bloom BAPA, that's been developed by one of the perinatal mental health specialists in our area, as well as just a risk factor checklist, so that if folks are in a community setting or a clinical setting, they can start the conversation about the risk that may be present with a birthing person to experience a PMAD. So hopefully that's helpful to you, Stephanie.
I see another question here from Eddie Bush. Do you want to speak up?
I think Eddie put in the chat a few minutes ago that his mic was messed up.
Okay. Well, the question was, have you any drawback from caregivers in the ED or other medical facilities who have little interest in receiving that warm transfer from other caregivers?
Yeah, so I just responded in the chat also. That was, a suggestion by a clinician. She also happened to be, a provider at that particular hospital that had the ED. And so maybe that helped facilitate that communication for her. She did not mention that she'd had that it was any drawbacks to doing that, but it could have been because of the relationship that she had with that particular ED as well. And I did just want to add a little, Ashley mentioned the pilot that our partners in Fresno is doing with their local WIC to have the blood pressure kiosk available, because blood pressure is not something that WIC traditionally does. And so that person will have their printout of what their BP is that day. And the WIC office worked with their public health nurses to also develop kind of a flow diagram and a decision tree, if you will, on if the person comes back and has questions about what that BP is, just so that they can offer some baseline information to them. This looks really good for where you are, or, we may need to do a warm handoff to your physician, or you definitely need to get in and take this when you see your provider the next time. So we are looking forward to receiving information and learning from what their experience is for that pilot initiative, and we'll be happy to share that out, as well as we've had some other communities thinking through how they might be able to do the same.
Great. Are there any further comments or questions? Feel free to open your mic.
Hi, I have one follow-up comment. In Iowa, where I'm from, we're doing the severe hypertension bundle as well. And on a recent call with AIM National States, I forget what state it was, but they were doing follow-up visits, nursing follow-up visits for lactation services through their, I believe, WIC program. It could have been their OB postpartum area, though, because they were also doing bilirubin checks on the baby with a billimeter. And they decided to add blood pressure checks on the mom when the newborn got brought in. And sometimes global, I might be getting too much in the weeds, but the global billing for maternity care doesn't allow billing for follow-up services like that. But for the newborn, it does. So they were able to, pay for the nurse's time for the lactation visit and the, Billy, and then it didn't take much additional time for them to check the mom's blood pressure and follow up if needed.
Thank you. And I heard somebody else speak up.
Yes, hi. My name's Kara. I work for a Blue Cross Blue Shield health plan in near Rochester, New York. I've seen the safety bundles for the hospital, for a number of years now, and I'm excited that it's moving out into the community, and maybe I've missed it for a while, but are there other bundles? We do care management over the phone for our members, and we're really looking at health equity pretty intensely, and I would love to be able to present something to my care management team along the lines of safety bundles, because we were going to try to develop some on our own.
Oh, please don't do that. Please let us work with you on those. Yes, we have the postpartum bundle that was mentioned, the maternal mental health, and I think if we go back to the slides, Deborah was going to mention the recently launched IPV bundle. And we have finished testing and are currently just working on final tweaks to 2 community care for chronic conditions bundles, one that's addressing pregnancy and one that's addressing the time in postpartum. And those chronic condition bundles look at 3 main drivers of cardiovascular disease with healthy weight, hypertension, and diabetes.
Great. Is there, an email or someone I could reach out to after this to put this together for us? Not together for us, but that I can work with?
Absolutely. Absolutely. I put mine in the chat earlier, and I think the end of the presentation has our general AIM CCI email, but we always say there's no wrong door at AIM CCI. So if you reach out to any of us, we're a small but mighty team, and we will certainly address anyone who reaches out to us.
Great. Thank you so much.
And Karen, I don't know that you really were introduced, but Karen Schutz is our senior program manager for AIM CCI, and she just dropped her email in the chat as well.
Thanks, Ashley. No, I joined late because I was running from the AMCHIP meeting today. So glad to be here now.
So Karen, would you also add, and thank you for dropping in both your email address and the AIM CCI website, and for those who might be interested in being an AIM CCI site, the application would be on the CCI website, or if you have a link to the application, you can drop it in as well. But I want to say for each one of those bundles, the pilot sites have worked with the staff to develop, and the subject matter experts to develop a wealth of resources to support each one of those bundles. So each one of those bundles is supported by a list of resources in around mental health, interpersonal violence, postpartum care at the community level, and then now the chronic disease bundle. And thank you, Ashley, for adding the Jackson Hole contextualized stress measure as well, because we were just talking about that back and forth on the email yesterday. With the article about how women of color experience depression differently, and sometimes need a different screening tool. And that's one that Dr. Hogan and Dr. Fleda Mass Jackson and others developed several years ago for women of color. So that resource that supports the mental health bundle has several resources in it, depression screening tools and other resources that could be helpful for all of you on this call.
I just want to thank everyone, Nikki, Deborah, and Ashley so much, and Kara. It's so helpful in getting this going. Getting this happening. Very excellent presentation and great questions. And we have recorded it, and we will make that and the slides available, and then the other resources that have been requested that we can add. So really appreciate you being here. Thanks so much. And thanks to AIM CCI for all the great work. Bye.
Thank you.